We are talking now about decision-making in glaucoma therapy. So we've actually covered a lot of these questions already. So I'm just going to focus on how we treat patients, why we treat patients, and kind of some treatment paradigms and the process, the steps that we're thinking about, okay? So we're going to be weighing our options between medicines and lasers, and then moving on to more definitive things or more aggressive things like surgery with minimally invasive glaucoma surgery, and then our traditional glaucoma surgeries. So our first patient is an older woman who's referred to you for evaluation. She has a history of high blood pressure, type 2 diabetes, and asthma. And she's complaining of some blurry vision. So her vision is 20/50 in the right and 20/40 in the left. Her intraocular pressures are somewhat elevated, 26 in the right, 22 in the left. She has a moderate cataract on exam. And her dilated exam, as we can see, she has some cupping, right eye more so than left, and her visual field has some damage, right eye more than left. So this is a pretty obvious case, I think. This person has glaucoma. And so we have to figure out, how are we treating this person? Are we treating this person, and how are we treating them? So I'm going to say, yes, we're treating it. So how do we evaluate? Where do we start? So first, we look at our patient. Are we looking at a 95-year-old little teeny frail lady? Are we looking at a 60-year-old robust person? We look at their medical history. What medications are they taking? What else is going on in their bodies? Obviously, look at their current medications, and then we look at their angle, of course, to determine what kind of options do we have here. So in her case, she has diabetes and high blood pressure, and she's on a beta blocker and also on medications for her diabetes, a pill, and she's taking an albuterol inhaler, not a steroid. Her angles are open and have a nice amount of pigment in the PTM. So we're thinking like, okay, what can we offer this lady? Can we offer her medicine? Can we offer her a laser? So she actually would be a great candidate for a selective laser trabeculoplasty or SLT laser. But we could also start her on medications, and then further down the line, think about minimally invasive glaucoma surgeries or incisional surgery. So when we discuss what we're going to do for patients, I always open up the topic to them. I said, okay, well, we can start you on medication, or we can do a laser, depending on their angle morphology. So there's pros and cons of everything, right? So obviously we know that a medication, that's kind of a layup. It works pretty quickly. We can generally get a pretty predictable result if we start people on eye drops. But the cons are not insignificant. They're costly. They are not always easy to use. They can cause side effects. And the biggest thing is compliance. I have no idea what my patients are doing most of the time with their eye drops. And I can tell you many of them are not using them except the morning they come to see me. So, and then the laser, the pros are it's low cost, especially if they have insurance. It's a low cost to the patient. It can reduce or just eliminate a medical burden. And it can be repeatable for the SLT. The cons here is it does take time to work, and a selective laser trabeculoplasty takes about 6 to 8 weeks to kick in. It may not work. Sometimes even if an angle is open and they have decent pigment, doesn't necessarily bring the pressure down significantly. And you do need good angle anatomy and a cooperative patient certainly for both an iridotomy and an SLT. So in her case, she did not want to do a laser. So she said, okay, I want to take eye drops. I said, okay. So we have so many eye drops to choose from. So where do I make a decision? How do I start? So the first line medications are generally either a prostaglandin or a beta blocker eye drop. So the prostaglandins, we all know them, the little green bottle, travoprost and latanoprost and bimatoprost, tafloprost and Vyzulta. So the pros of these are they're really well tolerated systemically, sometimes a little headache, sometimes GI upset, that's pretty rare. And they're only one time a day, so they're easy to take. The cons are mostly topical, but they're significant. They can cause really red, dry eyes. And lash growth, which most people don't complain about, but they can be notable if you have it only in one eye. It can actually cause iris color changes, which is rare, but irreversible once it happens. And these tend to happen in like hazily light green eyes with freckles. And it's not considered pre-malignant to have an iris color change, but it's very notable and when it does happen and irreversible, as well as fat atrophy in the orbit. And then we have our beta blocker drops, the yellow tops, which are timolol, betaxolol. Again, these are great. They work quickly, useful in an angle closure attack. They can be used 1 or 2 times a day, but they do have significant systemic cons. So they can affect the lungs and the heart, and they can cause depression, lethargy, and impotence. So our next tier is, these are good secondary players. They're usually not enough as a primary medication. Some people, but most people, you're going to use these in conjunction with your primary, with your first line. So these include the alpha-GAM-P, brimonidine, iopidine, and propine. Propine is not really around that much anymore. They work really fast, and again, useful in acute attacks. They have to be used at least twice a day, often 3 times a day. They do have significant cons in that they can cause, these are like the #1 cause of an allergy, specifically a follicular allergy in the eye. Really classic giant follicles can happen with brimonidine, and that could be either in conjunction and with combination medication or on its own, but very, very classic and notable. So if you ever see that in a boards exam, somebody comes in beefy, itchy eyes, it's brimonidine. It can also cause very significantly sleepiness or lethargy, not just in the elderly and very young, but a lot of people cannot use it during their workday because it makes them very sleepy. The second class here is the carbonic anhydrase inhibitors, which are dorzolamide and brinzolamide. Again, they work quickly, they work well with others. Usually, again, a 2 or 3 times a day dosing. The cons with the carbonic anhydrase inhibitors are mostly topical. It can actually cause a pretty significant dermatitis around the eyelids. They get these like kind of red, ugly looking lids. It can cause a topical allergy. Mostly it's just very corneal toxic, especially with dorzolamide, less so with brinzolamide. Corneal specialists really do not like this class of medication because the corneas really do look kind of crappy, but they work well. And then combination medications like brimonidine timolol and dorzolamide timolol and brinzolamide brimonidine are great because you can combine 2 medications into 1 bottle, but the cons are they are more expensive, and if the person does not use that bottle, they've just missed 2 medications rather than 1. So the next tier include the Rho kinase inhibitors and miotics and Durista. So the reason why I put these as next tier is because the side effects tend to be much higher with these classes of medications, and the cost tends to be also higher, especially with the Rho kinase inhibitors and with Durista. So the Rho kinase inhibitors are Ropressa, which is notarsadil, and Rocklatan, which is a combination of notarsadil and latanoprost. These work super well. You take them 1 time a day. They are really, really effective in dropping the intraocular pressure. They work in a number of mechanisms, but they're very hard to take for a lot of patients. They really dramatic red eyes, especially with Ropressa, and with Rocklatan, really teary eyes. And so that could be a really hard sell for patients to stay on. They also have to be kept cold, and they are costly and not always covered by insurance. And then miotics, which we all know, the green bottle, they're useful in angle closure attacks. They bring down the pressure quickly. They're also useful in glaucoma. They are not used so commonly anymore because they have to be used at least 3 times a day to really have a prolonged effect. They cause a small miotic pupil. They're cataractogenic, and they can actually lead to a retinal detachment in certain people. So you always, before you put somebody on pilo, you want to make sure you have a good peripheral retinal exam. And then Durista, which is our injectable bimatoprost, which I'll talk about also later. I mean, it's wonderful. It's a little bimatoprost pellet that we inject into the anterior chamber. It floats down into the bottom there immediately. It lasts, really, the effect lasts up to 12 months. Of course, the con is that it's expensive. It's an injection. It's something you're doing to somebody in the office, and there's always a risk of infection. Small risk, but it's there. You can't do this with an open capsule or inflammatory situations, or if they have a narrow angle. And right now, it's only approved for a 1-time use. And then the lowest tier is the oral medications, Diamox or acetazolamide, and Neptazane, which is methazolamide. These work really fast. Again, they're really useful in acute situations. They're a good bridge until surgery, but we all know these are hard for people to take for prolonged periods of time. They cause malaise, loss of appetite. They change the taste. They can't drink carbonated beverages. They have to be used usually 2 to 3 times a day to really have a prolonged effect. And they can cause significant metabolite disruption and kidney stones. And patients that are on these long-term do need to have periodic monitoring for their bloods. So for this patient, she didn't want to have surgery, so I put her on latanoprost that she used nightly. And she came back a few weeks later. Her pressure is good, came down to 21/17, so we've had a significant drop in both eyes. But given her degree of cupping, especially in that right eye, I want better control. So where am I going now from here? Am I adding another bottle of medication, or am I talking to her about laser? So, of course, adding another bottle of medication increases the chance that they're not going to use it, and also increases their the cost and the convenience, and also their side effects. So I'm going to really try to push laser right now. So in her case, we're going to talk about selective laser trabeculoplasty, which is done for open angles. It's pretty easy for a patient to go through and for the doctors to do, especially if they have a well-pigmented trabecular meshwork. And it works better in highly pigmented trabecular meshwork and highly pigmented angle. We had talked about before about pigmentary dispersion, to be wary of doing too much laser because you can actually cause a pigment storm and pressure elevation that way. They don't work well for things like angle recession. And it's not an immediate, it takes really about 7 or 8 weeks to kick in. So if you need to get somebody's pressure down like immediately, this is not going to be the way to go. And then an iridotomy, of course, is for narrow angles. For anatomic narrow angles, to prevent an acute attack or somebody's had an attack to prevent further attacks. After you've done though if you're doing this in a non-acute setting, you're not really going to see that much of a pressure drop, maybe a couple of points, but you're not. I always warn people, especially if I'm doing this, they have a narrow angle, they're not symptomatic, their pressure is normal. I said, listen, this is probably not going to be the end of your glaucoma story. I'm just trying to prevent you to have a glaucoma attack, but you may still need treatment for garden variety glaucoma after this. And then there are side effects for the iridotomy. Depending on where you place the iridotomy, patients often complain of a streak of light. So depending on the patient's anatomy, I tend to still put them superiorly, like way under the eyelid, but sometimes they have to go really far superior so that the patient's eyelid is actually covering it a little bit. So other laser modalities, which I really won't go into in depth in the scope of this, is cyclophotocoagulation. So traditionally, the traditional CPC was a diode laser that we applied externally for end-stage eyes. These are eyes that with very little visual potential. We don't do this type of laser that much anymore. It's painful. You do need to have a block, and it is somewhat pro-inflammatory. There's actually a risk of like ptysis afterwards. So these are, again, patients that have like a blind, painful, hypertensive eye. You're trying to get their pressure down that way. Micropulse is basically a gentler version of the CPC, and it doesn't tend to be that effective, but it can be a bridge to a bigger surgery, and you also need a block for that. And then you have also the endoscopic cyclophotocoagulation, which is actually a probe within the eye, and you are lasering the ciliary processes and that can be done in combination with cataract surgery. So we offer her an SLT. She finally accepted. She came back 7 weeks later. That's always my sweet spot. It's like, come back 7 weeks later. Her pressure is great, and but now her vision, she's like, okay, my vision is not great now. I need to have my cataracts done. So what are our options now? So we're going to do cataract surgery anyway. I'm going to offer her MIGS, or minimally invasive glaucoma surgeries. So MIGS are relatively new on the market in the past few years. They're really useful. They have a very high safety profile, and with a rapid recovery, doesn't really contribute anything to their recovery period, but can contribute to better pressure control with minimal trauma to the target tissues. And we spare the conjunctiva with these types of surgeries, so it doesn't preclude further surgeries down the line. Again, the intraocular pressure lowering effect is modest, but in combination with cataract surgery, it is better than just doing cataract surgery alone. And these are theoretically done ab interno, but the Zen, which I'll show you a picture of in a minute, actually can be done also ab externo. So this one's a little bit of a hybrid. It's not quite a MIGS in that it doesn't necessarily spare the conjunctiva, and it's not always ab interno, but it's still in that class. MIGS are in 2 categories. We have the implantable ones and then non-implantable. So the implantable, they right now are only permissible with a cataract extraction, and these are the iStent and the Hydrus and the Zen. Again, the Zen is sort of a hybrid, and they're good for mild to moderate glaucoma. And then the non-implantable ones can be done standalone. So if somebody isn't ready for cataract surgery or has already had cataract surgery, you can do these types of surgeries. And these include the GAT, which I'll get to, the Cahook dual blade, trabectome, viscodilation, and the Trab 360. They are for more advanced disease, and they are good. They can also be used for narrow angle glaucoma. So some of the implantable MIGS are the main ones, actually. So there's the iStent. So this is the iStent Inject, which gives us 2 little stents. The iStent Infinite is the newest on the market. We have not gotten it yet in our hospital, but people in New York City are doing that, and that gives you 3 stents that you can place in separate clock hours throughout the nasal angle. The Hydrus is actually a scaffold that's implanted nasally or inferior, and then the Zen, again, this, like you can see this little tiny yellow tube, can be done ab externo, so you might pinch up the conjunctiva and go that way, or ab interno. The Zen is kind of interesting because it creates a bleb. It's not quite as benign as some of the other MIGS. It's a little bit harder it gives you better pressure control, but it's a little bit harder to manage. So the non-implantable MIGS include the Cahook dual blade goniotomy, which is that little, that's what it looks like. It just has this like little, almost like a little foot plate at the end of it, from New World Medical, or the I-Access, which can also, both of these sort of incise and remove trabecular meshwork, and they unroof Schlemm's canal. And then the GAT, which is the gonioscopy-assisted transluminal trabeculotomy, Trab 360s by Omni, they actually cut through you thread through the canal, and then you unroof Schlemm's canal that way. And it's much more aggressive than the Cahook dual blade or the I-Access, but it does lead to better pressure control, has much more risk of hyphema and inflammation. They're more powerful, and they tend to last longer, those things. So which MIGS do we do? A lot of times it's surgical preference, a surgeon's preference, a stent versus a goniotomy. And I'm constantly asking my colleagues, well, what would you do? And nobody ever has one answer. Everybody has their own preferences about what procedures they're more comfortable with, what they've had better experiences with, what they're willing to kind of do at that time of surgery. Stenting, like putting in a little iStent, it's very low risk. The thing is, there tends to be, it's a modest pressure drop, and over time the effect does wane. The Horizon trial, which was done several years ago, the reason why these were even approved was because they did it with a Hydrus stent, and it showed that the Hydrus with the cataract extraction brought a lower IOP and kept people off meds longer than just cataract extraction alone. And then the COMPARE study was a standalone study that compared the first generation iStent with the Hydrus. So with that COMPARE study, the Hydrus was actually found to be more effective to decrease the medication burden, which makes sense because the Hydrus does actually involve a longer area of the Schlemm's canal. It was a small study. It was only using the first generation iStent, so only one stent was going in, and there was no cataract extraction at that time combined with it. Follow-up studies showed that the cataract extraction with iStent Inject versus the cataract extraction with Hydrus actually were pretty similar moving forward over time. So again, it's sort of like, well, which one do you choose? You know, somebody who has a narrow angle, I'm going to go with something like a Cahook, a goniotomy, to open up that angle, remove some of the tissue. But if they have a wide open angle, depending on how medications they're using, I may just do the iStent. So our patient, she had a cataract extraction. We did the iStent Inject in the right eye. Her pressure was good after surgery, 14. She's still in latanoprost, but she's happy, we're happy. Of course, as happens with so much glaucoma, her pressure keeps going up again. So we keep on adding medications, maximal tolerated medical therapies reach, and the pressure is still too high and we're losing more field. What are we doing next? Now we're gonna have to bring out the big guns. So it's either basically a trabeculectomy or a tube. So the trabeculectomy, as I'm sure all of us know, we create a fistula with a scleral flap cover, and we can do it with or without mitomycin. You can actually get a very low target IOP with trabeculectomy. You can get down to 6, 8, but the risk of hypotony is very significant, as is the risk of a leak, a blood leak, or then scarring down over time. A tube is actually, you know, as I'm sure you guys all know, it's an implanted device where we put a little shell there, we snake a tube into the eye. You can do either a valved, where you're not going to get a super low pressure. Usually the IOP kind of balances out around 12, at least initially, or non-valved, which leads to a very low intraocular pressure. These you have to be careful with. You can't just implant a non-valved tube without, you have to tie it off and allow the eye to sort of equilibrate and then release that tie. So these are, if you need somebody to get their pressure down tomorrow, you're not going to do a non-valved, because yes, the pressure will get down tomorrow, but it will be 4, and you'll have all sorts of attendant risks. So you're more likely going to put in a valved tube to control the pressure, with the knowledge that you're not going to get their pressure down super low over time with a valve tube. With any tube, of course, there is also still a risk of hypotony and tube erosion, tube touch, either to the cornea or to the iris, and then a dislodging of an implant. So there's a reason why we're all so happy about MIGS, or the minimally invasive glaucoma surgeries, because trabs and tubes are just a long-term challenge for everybody. And of course, we all have our success stories and patients we've followed over years who are super happy with their little bleb or their tube. But even those, like over time, there's always a risk that something's gonna happen. Trabs can leak, those blebs can fail, and tubes can just stop working, and also have erosion over the tube itself. So there was a tube, or the tube versus trab study, which was first posted in 2008. They recently updated it. And it was almost 250 participants, and they were randomized to either a non-valve tube, such as a Bearvelt, or it was the Bearvelt, not such as Bearvelt, or a trab with mitomycin. So initially, during the first 2 years, a tube actually required more medication adjunctively. But then as the data expanded, we realized that there was really pretty equivalent versus the tube versus the trab, but how many medications they were taking. Initially, a trab had more surgical failures and more reoperations in the first few years. And then over time, those complication rates sort of evened out. And the visual loss was also evened out between the two groups. So I think nowadays we tend to defer a little bit more to a tube. Certainly I am, only because I feel like if this were my eye, I'd rather have a tube in it than a bleb. But a lot of it has to do with surgical preference as well, and just availability of devices that you have. But they're, over time, pretty equal. So in her case, I put in an Ahmed glaucoma valve, which is a valved tube with a pericardial patch graft, and she did well in the postoperative period. She's still on one medication. 6 months later, she's back on latanoprost, and everything is stable right now. Her vision, her visual field, her OCT, stable. But we know this is not the end of the journey. She's going to be my patient forever. She's probably going to have another surgery at some point. So when we evaluate a patient and when we talk about treating people, there's so many things that come into play. And again, you ask your colleague next to you who's had kind of similar experiences, and they might have a completely different sort of approach, especially when it comes to surgery and things like that. So a lot of it is you have to be very, it's very individualized to a patient. You know that when we're like therapists. We have to, these are patients, you're patients for the long haul. So you're always trying to think like, if this were my sister or my mother or my daughter, what am I doing with this person to make their lives better, to stabilize their vision, and certainly try to not make things worse. So anyways, that's the end of this one.